I think now we can start. It's 6:30 now. Dr. Shroff probably must be on his way to. He has joined.
Yeah.
Good evening, sir.
Good evening, everyone. Good evening. And
Good.
Happy New Year.
Happy New Year, sir. Happy New Year, Dr. Shroff.
Happy New Year.
Happy New Year, sirs, to all of you.
Yeah.
So I think we may begin now.
Yes, sir.
I welcome you all to this DCD series under the ISOT AGs, and we look forward to hearing from one of the not one of the pioneer in the campaign successfully for almost last so many years, and finally has proved his mantle by having done the first ever NRP perfused DCD liver transplantation about a month back, and the patients, the recipients of the kidneys as well as the liver, they went home successfully, very healthily, and they have done very well. So that goes on to demonstrate the success and the productivity of this resource of donation after circulatory death, which lies totally unutilized in our country. So let us hear from Dr. Avni Seth how we can probably take it up at our centers as well. Over to you, sir. And Amol, you can probably make the introductory remarks, and we can
Yes,
start.
So, good evening and very warm welcome and Happy New Year's to all of you. This is a good topic to begin the year academically. So, this is our second session of ISOT DCD webinar series conducted on first Thursday of every month, 6:30 p.m. While clinical feasibility of DCD is evolving in India, concern related to the legal clarity, ethical safeground on documentations, consent continue to the major safeguard. Today's session is designed to address these issues in practical, reassuring, and India-relevant manner, sir. So it is my honor and privilege to introduce Speaker Dr. Colonel Avni Seth, sir, Vishishta Seva Medal. Dr. Seth is a country's head of Manipal Organ Sharing and Transplant and chairman of Institute of Gastroenterology and Hepatobiliary Pancreatic Sciences, Manipal Group of Hospital, New Delhi. He is also a chairman of Restorative Institute of Gut Health and Transplantation of a Stool and a respected member of Apex Technical Committee of NATO Government of India. And sir brings with him a unique blend of clinical expertise, administrative leadership, and policy level involvement in organ donation and transplantations. We are especially honored to learn from him, sir, and I welcome you, sir. And with that, we have two esteemed panelists with us. Dr. Anil Kumar, sir. Sir is a director of NATO and Apex body for organ transplantations and allocations. And Dr. Sunil Shroff, sir, a senior consultant urologist, Madras Medical Mission Hospital, Chennai, and managing trustee, Mohan Foundation, past president, Indian Society of Organ Transplantation, with his huge experience in the organ donation and organ transplantation. I welcome you on the behalf of Indian Society of Organ Transplantation, sir. Now I request Dr. Avni Seth, sir, to please start with his talk. I request Ashish ji, our technical person, to start this talk.
Thank you.
Meanwhile, I request every attendee to post their any questions in the chat box of our Zoom meeting. I will take one or two interested questions with the sir. So I request every attendee to continue post their questions in the chat box. Now we'll hear from the sir.
So good evening, everyone, and a very happy new year. And it seems very appropriate that we are talking about DCD as the new year has started. And my task is to share with you what we have done in the last few years and how the legal and ethical framework on DCD has evolved over the last 10 years that we have been working on it. And to have Dr. Anil Kumar and Dr. Shroff chairing this session is a real honor. So just to give you a little background, that if you look at a devastating brain injury, if a patient reaches the hospital and gets onto a ventilator, either they recover or recover with disability. If they develop brain death, we have been focusing on this part for organ donation in the country. But what about those who develop circulatory death? So this part has been ignored so far in the country. And how often does this happen? Take a look. This was a study that we published way back in 2009 when I was in the armed forces. And if you see here, 735 patients followed up on ventilator. And if death was to happen after devastating brain injury, 30% developed brain death, but 70% died with the circulatory death. So, which means we have been focusing only on 30% of people who could end up as organ donors. So we can definitely do more in this space. And to show you how much the world is doing in this space, if you see these figures of 2024, out of 46,000 odd donors across the world, 28% have been DCD and about 72% have been donations after brain death. So, well, yeah, we are lagging far behind, and you've already had 1 or 2 seminars on DCD. So this classification must be familiar. But just to share with you that in a country like ours, where we do not have a presumed consent, categories 1 and 2 would not be applicable. But this is what we need to focus on. Our immediate focus has to be in a cardiac arrest in a brain dead donor, an unexpected arrest in an ICU situation, and of course now with withdrawal of life support treatment becoming possible, we can talk about DCD3 as time goes along. So let's see where we are in this. So my interest in DCD started in 2014 when we had this patient in my hospital, 63-year-old with a cerebrovascular accident, apnea test suggestive of brain death. The family gave consent for organ donation, but they also said that please go ahead with organ retrieval after they do some prayers, akhand part. And while the prayers was on, the heart stopped. So our immediate question was that could we have done a DCD4? And there was very little clarity what is the legal and ethical situation in our country at that time. So what we did, we hosted a national conference. This is the first ever meeting in 2015 on DCD. And this was again done in my Fortis hospital. We had international faculty. We had Dr. Anil Kumar, we had Dr. Shroff, everybody there. And we brainstormed. And the first question that was addressed was, does the law in India allow for DCD? And when we read up the THOA a bit carefully, we realized that it was already there that organ donation could be possible in a person, diseased person, means in whom disappearance of life occurs by reason of brainstem death or in a cardiopulmonary sense. So we realized that our law said that DCD can be done in India. So that was good news. So the next question was, do we have a consent form? So when we looked at the Form 8, which is the consent form for brain death, we found that there also it said that consent is given when declared dead by brainstem death or death. So circulatory death was covered in the consent form also. So it was then that we realized that we can go ahead with DCD in our country. And then, of course, I went to Spain in 2016 and again in 2017 to understand the whole process. And again in 2019, something happened in the country. This was the 50-year-old in Ruby Hall Clinic. Again, massive cerebrovascular accident. Family was very keen on donation. They said, you please do DBD, DCD, whatever you want, but please take the organs. But despite the president of the Indian Society of Critical Care Medicine being in the same hospital, the hospital administration was not sure whether DCD can be done in India. So again, this was a situation of possibly a DCD 5, but we did not go ahead. And look at this, as recently as 2023, this is one of my Manipal hospitals. I am based out of Delhi, but we have now 49 Manipal hospitals. And this was in one of the Bangalore hospitals. 30-year-old had a brainstem bleeding, GCS3, and there was no brain death, but there was extensive hypoxic brain damage. The family was keen for donation. He was a suitable candidate. But when the THOA was approached, they said that we do not have clarity. We don't have proper, clear guidelines on DCD. So again, issues of clarity, whether it's legal or not in India, despite now 7-8 years that we spoke about it. So the first paper that we published, this was with 9 societies, was in 2022, and this covered for the first time especially the ethical and legal aspects, and especially how to go ahead with a DCD 4 or a DCD 5 situation. And I'll show you a few things relevant here. So the one thing that we were able to sort out in this paper was what to do if there is a cardiac arrest in a potential brain dead person. So the normal pathway that was being followed in the country is that the family has consented, there's a cardiac arrest, and we were doing a CPR for 30 minutes, up to 30 minutes. If it was revived, then we go brain death pathway, DBD. If not revived, the organs were lost. So our question was that if the family is already agreed and there's a cardiac arrest, could we go straight for a DCD-4? So let's address what is the legal and ethical status on this. Is CPR required in a setting of DCD-4? So we divided this into 3 scenarios. So scenario 1 was where both tests for brain death, both set of tests have been done more than 6 hours apart, and before the organs are able to be retrieved, the patient has an arrest. Brain death declaration has already taken place, so we can go ahead, not a problem. The problem was here. This is how PGI Chandigarh and a few of our hospitals were performing DCD kidney transplantation. That means the first set of tests were done, the second have still not been done. Families shown keenness for organ donation, and there is a cardiac arrest. So 30-minute CPR was being done, then the patient was being declared dead, then the no-touch 5 minutes, and then we were going ahead with the DCD process. So our concern here was that so much ischemia happening to all the organs. Kidney transplantation in this setting may be possible because the early graft dysfunction one could tackle with dialysis, etc. But the other organ transplant cannot be done with this kind of situation. And we were a bit uncomfortable doing a cardiac arrest in a patient whom we knew was brain dead. But because the second set was not done, legally, everyone was wondering what to do. So this is the situation. And what we realized the best way to do here would be to do something like this, where patient is unstable after the first set of tests, we get a do not attempt resuscitation signed by the family. And once they have done that, then that we don't have to do a CPR after that. So this is the important message here, that if your patient with brain death is unstable, your first set of tests has been done, get the DNR signed by the family so that at least you save those 30 minutes of CPR and you can go straight down to the DCD pathway. So to differentiate between brain death and DCD, I just put this slide here to show everyone that the heart is beating in brain death, but it's not in DCD. The cause of death, our donor pool can be expanded in DCD. You could have neurological or respiratory illnesses, the organ donation can be done. This is easier to accept by the family. There's only one doctor which is required. We follow a 5-minute no-touch period before we declare death in these patients. But the problem in DCD is that ischemia times are prolonged. We don't have much time. We can utilize all the organs except the small bowel, which the world is still working on. And very importantly, if we want to do DCD transplant for organs other than kidney, we must have some kind of perfusion for the organs. Either we put them in a machine perfusion, which is very expensive, although we are trying to develop affordable machines in our country, or we do a normothermic regional perfusion. So let's see some ethical aspects of all this. So when we talk of DCD3, the question often asked still is whether withdrawal of life support treatment is allowed in India. So the answer came with the Supreme Court judgment of 2023 that once a futility has been reasonably established by the treating team, we have a primary medical board, and then once they feel okay that we can go ahead with withdrawal of support, we have a secondary medical board. I won't go too much into detail except just to tell you that the procedure is well laid out. And some states like Karnataka have done a very good thing that the brain death committee functions as a secondary medical board. So you don't have to take any special permissions from the CMO. So this whole process has been charted, but still not followed as a routine in the country. And the ethical issue here is that establishing futility is not easy. And what it means is that the treatment is futile or non-beneficial, but there is no legal definition. And it is often used to describe treatment which has no benefit, cannot achieve its purpose, or is not in the person's best interest. Various types of futility are described. One is a physiological, where the treatment that cannot achieve its physiological aim. A quantitative futility, where there's a less than 1% chance of succeeding. Imminent demise futility, whatever intervention we do, the risk of death is almost certain. Lethal condition futility and qualitative futility. So futility is often spoken about, but then we are doing it on a day-to-day basis in all our hospitals. We are doing futility assessment and LAMA without any scientific approach. So what we do is when patients go away on LAMA or DAMA, whatever you want to call it, it's a total lack of dignity in death, and the family is also denied an opportunity to donate organs and tissues. So if in all these patients we are able to withdraw support in a proper manner and then offer the family the opportunity to donate organs, that is the way we would like to see. So what are the ethical issues once we withdraw support and try to take the organs? As we saw recently, there was a lot of controversy in the US when the care was being withdrawn and the patient began to wake up and became better. So the prognostic fog, where people talk of a rushed decision making towards organ donation and overreach by the OPOs and similar organizations where their focus is on organ donation. Similarly, some people feel that there's a lot of conflict of interest in the ICU. ICU staff is supposed to be talking about saving lives, but whereas in a DCD situation especially, simultaneous preparations are required, usually by the same team. Organ preserving interventions where we use heparin and we put lines in advance into the groin, etc. All these, again, I'll talk more when we talk of NRP. Again, there is a thought that we may be violating the dead donor rule. For example, if you are reactivating the heart, reanimation of the heart, people say, again, is something which we should be looking at carefully. And also, if there is any blood supply happening to the brain during NRP, and again, that could lead to some kind of ethical issues. Some people feel that the death is literally stolen from the family, that there is no intimacy, privacy, especially when the withdrawal of support is done in the OT. It's a very impersonal and a medicalized way of saying goodbye to your loved one. So ethical issues are plenty, but I think we have been able to sort out quite a few of them. And this is we published a consensus statement. This time we had 12 societies on board. and we spent almost 2 years publishing this. And this is mainly on the controlled DCD situation where we are withdrawing support, how to go about it. So this is the pathway, again, to be understood, to be able to understand the legal and the ethical aspects, that once we withdraw life support, the BP begins to go down, and the threshold value in some countries is 70, say 50 millimeters. When the blood pressure goes below 50, that is the time the ischemia to organs will start. And after a while, the heart stops, that is the asystole. Then we wait for 5 minutes. This is where the death is declared. And then we go ahead with the organ preservation and retrieval. So the agonal phase is defined as the time between starting of withdrawal of life support to cardiac standstill. Warm ischemia from cardiac standstill till organ preservation. But the more important one is the functional warm ischemia, where once the BP is below 50 millimeters of mercury, till we start organ preservation. So all this is happening in the ICU or in the OT, but we have to remember that 20% of the time, cardiac arrest does not happen even when we switch off the ventilator and stop inotropes, etc., in such patients. And when that happens, and more than 2 hours have elapsed, then the organs are not going to function, and then we stand down for DCD and get the patient back for the care in the ICU. So these are the things to remember in a DCD-3. And just to show you that now we have these forms made for WLST, where this is courtesy Dr. Mani, who is part of our national team on this. So signature of family members, signature of primary medical board. Let me show you a close-up. This again, courtesy Dr. Mani. So where we have the primary medical board signing, the secondary medical board signing, and we just notify. We don't need any permissions for withdrawal of support. Just an email can be sent to the judicial magistrate first class office. So this WLST needs to become a routine part of end-of-life care. We can't talk about DCD all the time. But once the family agrees to a withdrawal of support, and then only the topic of DCD should be approached. So where are we in the country? You see, this is another way of looking at which I want to talk to you about, that if there is a devastating brain injury and there's a patient on ventilator with coma, if they develop brain death, we can go down the DBD pathway, but if the heart stops, we do what we call a DCD-4. If there is a sudden cardiac arrest in an ICU, family is willing for donation, this becomes DCD-5. DCD-3 is where we are doing after withdrawal of life support. So we have done quite a few of these in our country, and if we see here, DCD-4 and 5 have been done since 1999 in IKDRC, Ahmedabad, PGI Chandigarh, one case in ILBS, and now a few in Nagpur. But again, they're all DCD-4 and 5. In this situation, we are doing a super rapid recovery and static cold storage. And when we use kidneys like this, early graft dysfunction is very common. Almost 30% will require dialysis support, but the long-term results are equally good, if not better, than a DBD situation. Our problem is that we need to move beyond the kidneys. And if we have to do a liver transplantation with a super rapid recovery, there's a high chance of ischemic biliopathy. So for this, we either need to have a machine perfusion or a normothermic perfusion. And the legal aspects of these and the ethical aspects become more and more. So machine perfusion in India has been tried. Here is some of us in Delhi 2018 working on an organox. 16 cases were done, but then it was too expensive, and the problem was that if we put a liver on this machine, spend about 5 lakh rupees, and then not ending up using the organ, then who would pay for it? So this didn't work. And we've done more than 50 patients of what we call HOPE in the country. But these are all expensive when it comes to the liver. They've been done for DBD liver, never for DCD liver. So what can we do for DCD liver is this. So this is called NRP or normothermic regional perfusion. It could be either thoraco-abdominal or abdominal, and we just did the first abdominal NRP of the country, which I'll be sharing with you, and especially the legal and ethical aspects of it. But basically what is done is that we need to place lines in the groin, the femoral artery and vein on the right side, femoral artery on the left side, and then we, after 5 minutes of cardiac standstill, we attach an ECMO machine with the reservoir. So the blood goes into the reservoir through a pump, heat exchange, and here the oxygenation happens, and it is pushed back into the femoral artery and the blood enters back into the aorta. From the other side, from the left groin, we put a balloon, an inflated aortic balloon, just above the diaphragm so that there is no circulation happening into the chest or the brain. So with the balloon inflated here, we establish an abdominal NRP, and we did the first patient in my hospital only last month. So the initial brainstorming for NRP happened when I went to Ramaya University, spent some time with Dr. Sonal and his team. And then we made a national consortium on NRP. We had 22 members from all specialties, and we had various meetings on Zoom, more than 10 of them, and we met twice in person. And we had a very good thing, which was a demonstration. So we laid out all the equipment that was required, and we did a demonstration in the OT and in the ICU. And you can see here, all of us are in the OT. Dr. Shroff is here, and Dr. Anil Kumar is here, Dr. Philip joined, Ravi is here, Kumod. So a lot of experts in various organ transplants. We all got together and tried out what an NRP would look like. And this is, of course, Dr. Anil and Dr. Shroff. So what we did exactly, I would like to tell you so that we can talk about the problems that we faced. And of course, as a gastroenterologist, I had to certify myself for ECMO before I started to understand this whole process a little bit. And now we have published the consensus statement on how to do NRP in the country. This in the next issue of Indian Journal of Organ Transplant. You should be able to read this. And the ethical issues here, from what I just told you with NRP, one is placement of lines in the groin, administration of IV heparin while the patient is still alive. So I'll tell you how we went about that part. When we reanimate the heart, for example, in a thoracoabdominal NRP, the problem is that people say that death is declared on the basis of cardiac arrest. And once we put a heart, retrieve and put it in a machine, it starts to beat 100% of the time. So the very definition of death comes under a cloud. And now the world is moving more and more towards the final pathway should be the death by neurological criteria rather than by circulatory criteria after all this has happened. And of course, if the blood supply happens even a little bit to the brain and the brain begins to wake up, that would invalidate the dead donor rule. So when we do a thoracoabdominal NRP, we clamp the aortic vessels going up to the brain. And for abdominal NRP also, I showed you how we use the balloon. So this patient of ours that we just did, let me tell you a little bit about her. A very brave family. It was a 55-year-old teacher who had motor neuron disease, was confined to bed. And on 5th of November, they were brought to my hospital with labored breathing, altered sensorium for 6 hours. So low GCS, vitals were reasonably okay, pupils equal reacting. And you see this, there was marked acidosis and respiratory buildup of CO2. So in this situation, the family were very clear they do not want any resuscitation, they do not want any ventilator. So she was put on an IV, shifted to ICU. They expressed their desire that we should let her go in peace, donate organs if possible. So we counseled them on DCD and they agreed for NRP, and we did the first NRP of the country on this patient. We placed the femoral sheaths and IV heparin, and then once the heart stopped, we ran the NRP for 4 hours. And look at this, after 4 hours of running in a dead person, the lactate was still 1.7. So it worked fantastically. We transplanted the liver and the kidneys, and Kidneys, of course, have been done earlier, but not with NRP. Even the NRP kidneys work better than, a rapid retrieval. But look at how the liver worked. 48-year-old cirrhotic with MELD of 23 got the liver. We had a warm ischemia of time of 24 minutes, functional WIT of 24, WIT 16, cold ischemia was 4 hours. But see that the AST, ALT never went above 300. And the patient did so well. This is the message I got from Dr. Pamecha from ILBS, that there's great bile production, and patient was extubated in 12 hours and discharged after 2 weeks. For kidneys, the cold ischemia time was 14 hours. And one thing that we could talk about is the problems in allocation within about 4 hours. And that is where the ethics also come in, that when this time is so short, we have to work out a way that our waiting list is also looked after in the way it should be. The priorities should not be changed. But let me tell you, it was very difficult to find a recipient within 4 hours. And just to show you here, what we did was we developed, our consortium developed a low-cost hybrid ECMO, and the cost is just about 1 lakh. We spend less than 1 lakh in our patient. And if we do it at the cardiopulmonary bypass machine in the OT, the cost comes to 50,000. So this is not expensive at all. So in the consent form, of course, we use the form 8, but we also made a new form, which was made by the consortium. And here it was added because the family was keen to donate. So they don't mind signing this, that we have to use heparin to clot. And of course, the heparin has to be given while the heart is still pumping. And we access the access lines to the femorals, etc., wherever we want to put. These are things which are already now put in this consent form, which our consortium has developed. So there are various stages in DCD program in a country. We start with a super rapid retrieval, go on to where we take the kidneys. Now we've done the first abdominal NRP. So we had taken the liver, it worked beautifully. Our next stage should be an abdominal NRP, and the lung retrieval should be simple in this program. So that happens, and then finally, when the thoracoabdominal NRP is done and we take the lung and the heart, that is the time the ethical dilemmas become more and more, because heart removed from a dead person and then starts to beat again and gets a new life. The definition of death itself gets questioned. And if any blood goes to the brain and the brain gets a little bit of reactivation, that again would raise some ethical issues. Although newer studies from Spain have shown that hardly any blood flows into the brain when we do an NRP, the way it is currently done with clamping of the vessels from the arch of aorta. To summarize, ladies and gentlemen, circulatory death is easier to understand as compared to brain death. Outcomes of DCD are comparable, and legal and ethical issues are now fairly sorted out in the last 10 years that we have been working on it. DCD 4 and 5, that is in a brain death situation or a sudden cardiac arrest in ICU, can be done straight away. As far as DCD 3 is concerned, WLST is now possible after the Supreme Court judgment. We should avoid the practice of LAMA and DAMA, but we should do hundreds of WLST and detach that from DCD. And once we are very good at WLST, we should talk about DCD program. And NRP is the way forward for enabling a multi-organ DCD transplant. And this is the tree of life in my hospital, in Manipal Hospital, Delhi. And every time we have a donation, we put the name and date of the donor, and the leaves continue to grow. Thank you, everyone, for your patient hearing.
An excellent overview, Avnish.
Thank you, sir. Thank you very much for your excellent and highly insightful presentation, sir.
Thank you.
With the permissions, now we can begin with our panel discussion, sir. Sir, first question is to Dr. Avnish Seth, sir. Sir, based on your recent experience with successful DCD using NRP in India, what key legal ethical safeguard help ensure transparency, trust, and compliance throughout the process, sir?
See, first, as I have presented, that there is no legal issue. I think we have to stop talking about whether DCD is legal in India or not. So, no legal issue.